Dr. Satish Rao is affiliated to Birmingham Women and Children's Hospital, and his areas of interest are severe asthma, sleep disorders, technology-dependent children, rare and orphan lung disease.
Thank you very much. Good morning, ladies and gentlemen. It's an absolute pleasure to be here today in this great city, and I would like to thank the organizers of Respicon for this invitation. So this morning, I'm going to set the scene talking about phenotypes and endotypes of asthma. I would like to start with some acknowledgements. Deeply indebted to children, young adults, and families at Birmingham Women's and Children's Hospital who have given us the privilege of looking after them. Deeply indebted to staff at the department at Children's Hospital and the organizers of Respicon. And I don't have any conflict of interest to declare for this particular talk. So we know that asthma is most common chronic condition that affects children and youngsters across the globe. We also know that asthma is not a single disease entity. Asthma is in fact a heterogeneous disorder. It has various presentations, various courses of illness, and various prognosis. So this has essentially led to considerable interest in trying to create some homogeneous subtypes within this heterogeneous disorder so that we can think about different treatments for different subgroups and also maybe predict the prognosis for each of these subgroups. So various attempts have happened over the decades, and I will just try to summarize that and perhaps just tease out some clinical implications of this. For the purpose of this talk, a phenotype is what we see of the children and youngsters in front of us, whether it's in our office, in clinics, or on the ward. So they are the clinical picture, whereas the endotype is the underlying pathophysiological process. So let's start with preschool wheezers. Now, preschool wheezers are the most heterogeneous group of children presenting to us with wheeze. Now, these include post-bronchiolitic cough and wheeze, particularly after RSV. This might include transient viral wheezers. This might include some asthmatics, and so on and so forth. So broadly, these children could be subdivided into two groups. So there is this group of episodic viral-triggered wheeze. So these are children who tend to have a wheeze just with viral infections. They recover fully following the viral infections. They have very little in between the viral infections, so they have no interval symptoms. And they probably will have neutrophilic airway inflammation. Now, I use the word probably because it's not as robust as it is in adults. This kind of an endotypic classification isn't very robust, but majority of them have a neutrophilic airway inflammation. In contrast to this, there are a group of children who have wheeze triggered by multiple triggers. So these children might have interval symptoms in between the episodes triggered by viruses. They tend to have exercise-induced symptoms and so on and so forth. They may begin to show signs of atopy, and in some children we do see quite significant atopy in form of really significant eczemas or food allergies and so on. In these children, they begin to start showing aeroallergen sensitization, and they might have elevated blood eosinophils. This group is of particular interest because the airway remodeling, it is thought, and there is enough evidence to say that the airway remodeling probably starts in this age group. So in fact, by the time they get to school age, the limitations of the airway flow have already been set. So therefore, there is considerable sort of interest in this group, that this group probably is a group where we should be targeting with some inhaled corticosteroids to dampen down the inflammation. Now, if we think about school-age children and youngsters, then there are many different types of classifications that have essentially come about in the recent years. So there is this classification based on airway inflammation. There is this classification based on severe asthma as what European Respiratory Society defines, which I will come to in a second. Then there are latest use of statistical, newer sort of sophisticated statistical analysis like latent class and cluster analysis that essentially helps us to group these kids into sort of homogeneous subtypes within this heterogeneous group. So let's start with airway inflammation. Now, broadly, what is agreed is T helper 2 high or T helper 2 response low. That is the first sort of classification. Let me start with what happens inside the lungs, and then we can relate that to what happens when we look at these kids and youngsters clinically. So this particular phenotype and endotype accounts for maybe 85% of the children that we see with asthma and youngsters that we see with asthma. So they start off with eosinophilic airway inflammation. They have Th2 pathway-triggered cytokine response, the IL-4, IL-5, and IL-13 mediated, mast cell activation leading to IgE synthesis. If we were to look inside their airways, either using bronchoalveolar lavage or induced sputum, we would see significant airway eosinophilia. And they would have raised forced exhaled nitric oxide measurements, blood eosinophils, and raised serum IgE. Now, clinically, these children and youngsters would present with a strong history of atopy, that might be significant dermatitis, food allergy, or rhinitis. They might present with significant history of family history of atopy. And usually they are thought to have good response to steroids. Now just hold that thought, and then we will come to some of the limitations with this classification. In contrast to this, there is the Th2 low classification. Now here, what is happening inside the airway is mainly neutrophilic, or it is a paucigranulocytic inflammation. That means there is a mixture of low-level inflammation with neutrophils and with eosinophils. It is a it is basically driven by IL-8, 17, and 22. In adults, there is a strong correlation with this type of inflammation and airway infection, whereas this correlation is less so in children. There are some studies that correlate with Moraxella infections in the airways and this type of inflammation. However, that link is not as strong as it is in adults. Theoretically, this group should respond better to antibiotics because it is neutrophilic inflammation, and especially macrolides. Now, there is paucity of data on consistency. Well, there are many studies that actually support, but equally there are other studies that do not support this hypothesis. This phenotype is less common in children, probably accounts for 15% or so of the asthmatics that we see. But it is important to recognize this particular phenotype with obesity. So children and youngsters with higher BMI are known to have more commonly neutrophilic inflammation. I mean, still the commonest form is the eosinophil-driven asthma, but neutrophilic inflammation is a bit more common. And this group tends to have variable response to steroids. So they present a particular challenge in management, really. But there are major problems with this kind of classification. Now, different types of endotypes, whether it is Th2 or Th2 high or Th2 low, when you are sat in the clinic with that particular patient or a youngster, they may actually present very similarly. So that is a major issue. And same endotypes, so the Th2 high response can present with various different phenotypes. So they could have a mild asthma, right up to severe asthma. So the fact that you have Th2 high or Th2 low doesn't necessarily comfortably box into a particular type of phenotype. What we also know in pediatrics is the airway inflammation is not fixed. I mean, Prasad's own study, he's going to be speaking next, has shown that the airway inflammation changes with time. About 60 to 70% of kids actually change from eosinophilic to non-eosinophilic inflammation over a period of year that they were studied. So the airway inflammation is not fixed. Even when they have neutrophilic airway inflammation, we do see Th2 type of response with cytokines, that's with IL-4 driven response. So there are a number of challenges with this type of classification. but it is a good, well, I don't know if it is a start, middle, or the end, but this has been going on for a number of years. Then if we look at problematic severe asthma, so they present as a specific phenotype. So problematic severe asthma, according to European Respiratory Society, is still, asthma which is uncontrolled on quite high doses of inhaled steroids, more than 800 micrograms per day of budesonide or more than 500 micrograms per day of fluticasone. Within this big group, there are two subgroups. There is a difficult to treat asthma. So the disease per se is not really that bad, but the children or youngsters continue to be symptomatic because they either have a poor technique or they are not adherent to their medications, they have continuing allergy exposure, or they may have something else with asthma. And breathing pattern disorder is something that we are seeing more and more in this patient group. Then we have severe treatment-resistant asthma, which they may have some of these factors affecting that, but once they have been reasonably controlled, a significant number of kids tend to have, it is a smaller proportion in the bigger scheme of things, but majority of them tend to have T2 high phenotype and endotype. There are other specific phenotypes to consider. Previous prematurity, so that's associated with fixed or variable airflow obstruction. They have very minimal airway inflammation as such. And similarly with sickle cell disease, again, it is driven by airway obstruction kind of pathology without much significant inflammation or bronchial hyperresponsiveness. Now, moving on to some of the latest developments over the last decade or so. These statistical analysis tools, latent class and cluster analysis, allows identification of some homogeneous subgroups within heterogeneous population. So they tend to encompass a variety of different variables, like, for example, age of onset. They might include atopic status, they might include duration of disease and rates of exacerbations, lung function, symptom control, and inflammatory biomarkers. As you can see here, it's very difficult to include the adherence or degree of adherence to treatment, which is something that, especially in UK, we face huge problem with poor adherence to treatment. It is very difficult to account for that within these variables. So I will just highlight a couple of approaches, and there are a number of cluster studies that are emerging by the day. This is quite interesting. This is a study from Inner City in United States. And what they did with this is they followed up 717 children and youngsters over a period of a year. They had worked with these children on the adherence side of things and making sure that some of the factors like inhaler techniques and adherence have been addressed. And then they essentially looked through for a year, and they came up with various clusters. So as you can see, some have lower degree of eosinophilic inflammation, normal lung function, minimal signs and symptoms, right up to cluster down here, which is higher degree of inflammation, obstructed lung function or an abnormal lung function with higher levels of airway inflammation. Similarly, the SARP study, severe asthma study, essentially was a bigger study including adults and children, but they had 118 children under 18 years of age. Majority of them, again, defined as severe, which is combination of ATS and very similar to the ERS kind of classification. In the severe group, they found lower asthma control test score, higher exacerbation, higher daily steroids requirement. They had lower lung function and higher bronchial responsiveness. Well, intuitively, we would all agree there is nothing surprising in this data here. But they did not find any difference in the inflammatory biomarkers. So they did not find any difference in eosinophils, whether it is sputum or blood, or IgE or pheno or degree of sensitization. So, there is that bit of disconnect between what we are seeing clinically to what is essentially happening inside the lung. So we are none the further here. Similarly, this is a severe asthma, 315 children. So they identified, somehow this slide has lost its formatting here. They identified two clusters. So first cluster is mainly eosinophilic driven on lots of inhaled steroids, more hospitalizations, And the second cluster of severe asthma was more neutrophilic driven, that was associated with obesity, and they had lesser response to inhaled steroids and systemic steroids. There are various, of course, biomarkers for endotyping, which probably Prasad will come to in a second. Our own study that is under review has essentially shown pheno is not useful for diagnosis. And what it boils down to finally is doing the basic treatment right. In the UK, we are leading transformation of clinical services where we are taking asthma care out into community. And by addressing certain basics like inhalers and making sure they are on inhaled steroids and making sure they are on the right equipment, essentially achieves better asthma control. So what I just want to say is, well, the endotype and phenotype side of things exist, but they might be more relevant to the more severe end of the spectrum, but we need to get our essential asthma treatment right for majority of our asthmatics. Thank you.
Thank you, Dr. Rao. Thank you very much for an enlightening session. Thank you.